you have tennis elbow and you never even played tennis? It can happen. I'm Dr. Paul Zalzal.
I'm Dr. Brad Wing. Today we have a guest.
I'm Dr. John Haverstock.
Welcome to Talking with Docs. You're in the right place. You're watching a video about your health. You're not watching a video about used cars, although those are important too.
Dr. Haverstock is an upper extremity surgeon. He's here today to talk to us about lateral epicondylitis or tennis elbow. So let's start at the beginning. What is lateral epicondylitis?
So it is a collection of tendons right here at the lateral epicondyle. So it's the bony outer side of our elbow. And that's where a lot of the muscles and tendons originate to extend our wrist back and our fingers. And it's very prone to aging, micro tears, and tissue damage.
Okay, and how did tennis get associated with this?
I think back in the day, the people that were working on this were finding that it was more in athletes, people who are more active in lawn tennis back then was.
So it's probably the backhand move with the tennis, right? Where you're extending the wrist.
Absolutely.
But more commonly, it's repetitive work type stuff. People that use a lot of screwdrivers, use their hands to make a living. So don't be despaired if you don't play tennis and you have this problem. So how does it show up? I'm assuming with pain.
Yeah, pain absolutely is the predominant thing, and it's usually, it might be a little bit more global, but it's on the outside of your elbow. It's not on the inside. It's not in the front. It's usually worse with activity, and it can be very, very difficult pain at first.
Okay.
Okay, and so those are the symptoms you'll have. Mm-hmm. So you're like, okay, something's going on. I'm going to go see my healthcare professional. What are some of the signs that the healthcare professional is going to look for to make the diagnosis of lateral epicondylitis?
I think the most important thing is pain at that specific location. So if you can touch around with one finger or a thumb and you're saying my pain is right in this one spot specifically, that's the number one thing. You might also have some weakness to extend your wrist or your fingers or with repetitive motions.
Okay, and that extension might also reproduce the pain. So you've got tenderness at the site, and maybe it's provoked by extending the wrist, extending the fingers, maybe with some weakness. And that's the kind of things that your healthcare professional is going to look for on physical examination.
Okay. After physical examination, we always go to investigation. So in orthopedics, we usually get an x-ray. Is there any point in getting an x-ray for this?
Not really.
Okay.
If you have other things going on, if you had a fall, if your elbow's kind of stuck and you can't move it, those are great reasons to have an x-ray. But with this specific diagnosis, if everything else has been normal, you do not need further imaging.
Okay. Is there any role for an ultrasound or MRI? Because guaranteed someone's going to put it, hey, I'm pushing my doc to try to get an MRI or an ultrasound because I don't believe that my doctor knows what they're talking about.
I would say it's low if you meet these things that we've been discussing here, but sometimes for surgical planning, before we go to the operating room, we'll get an ultrasound or an MRI. But typically, if the diagnosis is so focused in that pain, you don't need these other things.
I always get an x-ray. I always ask for an x-ray, even no matter what.
Make sure there's not like a tumor or
something
something
weird. Yeah, make sure there's nothing else going on in the bone.
Yeah.
Personally, that's my approach with this.
There you go.
In any case, okay, so you've got the history, the physical examination, the investigations plus or minus. Mm-hmm. Now, how do we treat tennis elbow, aka lateral epicondylitis?
So when your pain is acute and you're having trouble moving your arm and perhaps doing simple things at home, sometimes wearing a brace on your wrist, which doesn't totally make sense initially, it's a little bit counterintuitive, can relax the muscles that are being stressed up here at your elbow. So if it's just started, if it's a lot of pain, you're having trouble functioning, getting a simple wrist brace or something like a wrist rollerblading guard can help for a few weeks. I wouldn't wear it over the long term.
So just something to restrict flexion and extension of your wrist?
Yes.
Okay. So it doesn't have to be fancy.
Okay.
That's right.
So bracing.
Okay.
Yeah. Some people will find also success with what we call a counterforce brace. So it's a band, you've probably seen them, it's like a wide watch band almost, that's wrapped below the elbow, and that seems to alter the force and take some of the pressure off. So many people have seen those. Sometimes athletes seem to wear them.
Would you say it's worth a try?
Absolutely, as long as you don't make it too tight and cut off the circulation or pinch the nerves.
Okay.
All right, so you've got some kind of bracing, the wrist or even up here. Mm-hmm. Physical therapy, role for physio/physical therapy.
Yeah, so range of motion, they have some pain treatments they can do. And over the long run, things like specific stretches and strengthening. So strengthening that is eccentric has proven to work in this condition. And that means taking a load while the muscle is getting longer.
Right. All right? So we've got the bracing, the physical therapy. Is there a role for injections of any kind, either cortisone or PRP or anything like that?
Yes, so cortisone has been our standard go-to for a long time. It seems to work pretty well, and it's probably best at taking the pain away quickly. But the interesting newer thing is that it might not make a big difference in the medium or the long term. So after 6 weeks, it seems like it doesn't make a big difference compared to no injection or perhaps a different type of injection.
Okay. Any role for PRP? Paul mentioned PRP. It's fancy.
Yeah, so PRP does have some good evidence in this specific problem and location. So it's better in the medium and the long term, and that's what probably most people are interested in.
I would say that this is one of the only, well, one of the more common things that PRP actually has some evidence to back up its use in this sort of a pathology, as opposed to injecting it in your knee for arthritis, for example.
I'd say a couple things we glossed over. The first one for me, I'd say is, if you do this and it hurts, maybe don't do that. So like if it's tennis, I'd say stop playing tennis for a little while. If it's your job, it's obviously a little more tricky, but if you can modify your job. And then the second one for me is, what about medications, either orally or topically? What about the role of anti-inflammatories for something like this?
Yeah, that can certainly help the pain. You know, it was thought that this was an inflammation problem. Now we know that it's not actually an inflammation problem.
Good to clarify.
It's more of a degenerative problem, and we call it like tendinitis. Well, tendinosis. Itis implies inflammation, and that's not technically happening after the first few
So it's
days.
almost a misnomer then.
That's right.
Okay.
So medications, topical, oral, acetaminophen, anti-inflammatory, these can help your pain, which is initially part of the problem. And activity modification is a huge one.
Okay.
So forceful gripping, lifting, especially with your palm down, is an exacerbating thing. Because when you lift with your palm down, all the force is originating at the sore spot. So if you turn your palm up, if you're able to in that situation, avoiding, favoring your palm uplifting can certainly rest the area.
Okay. Good to know.
Harvesting carrots.
All
Be careful.
right. You can harvest carrots like this.
Well, yeah.
It's
Don't
awkward.
do it like that.
But so now you've done all the non-operative stuff. We are surgeons.
Yeah.
We'd like to talk about definitive surgical treatment if it plays a role. Where does it fall for lateral epicondylitis? Is it common?
It's not common. No, it is done because there are certain circumstances where this is lasting 6 to 12 months, and that's problematic for people. But most often I recommend surgery if this has been going on for a year. Some people say 6 months. We do know that the vast majority, like 98%, are going to get better over 6 to 12 months. It's a long time, but the symptoms are typically improving over that period.
And make no mistake, this can be very debilitating. We're not minimizing the symptoms that you have. So if you were going to get an operation, what would it look like? What do you do?
Yeah, so the zone of tendon that is deranged, it's kind of microscopically deranged. There might be some tears. You might have an ultrasound that says there's a partial thickness tear, or 1 or 5 millimeters. But what the surgery does is it involves removing that diseased tissue. There's some redundancy in the tendons around, so you can repair around it, but mostly we're taking out that diseased tissue either through an open approach or arthroscopic, and there's some fancy ways to do it with a needle in a special office.
Okay.
All right, so there's surgical intervention, which we always reserve for after the non-operative stuff has failed. That's the activity modification, anti-inflammatories, physical therapy, bracing, topicals, and time. Once all that's used up, then we say, okay, maybe we need to do surgery. Recognizing there's risks with surgery: heart attack, stroke, death, blood clot, infection, pneumonia, and probably one of the biggest problems with surgery in this area is that it comes back again.
Yeah.
You do the surgery and you still have pain after, or you have a relief for a while, then it comes back again, which can happen as well. So, common, not so common, this sort of thing?
It's a common problem for people in general because we're lifting, we're reaching, we're typing all of the time.
Yeah.
But the good news is for the vast majority of people, it's going to get better over weeks and months with these simple treatments.
Because it interferes with typing, we're not going to get a lot of comments from the people with it.
Leave a comment. Actually, if you have an experience with lateral epicondylitis, maybe put your keyboard upside down.
Or a short comment.
Or voice to text.
Me. Just type me and we'll know what you're talking about.
Now you know all about lateral epicondylitis and that there is hope for you despite having pain for months potentially. If you like this video, please like it, subscribe to our channel.
Did you honestly say upside down keyboard?
Yeah.
How are you going to see
Maybe
the-
there's a market for
You
that.
can't see the keys.
Well, maybe there's a mirror underneath that.
Remember, you are in charge of your own health.
Dragon's Den. Call me. Thanks, Dr. Haverstock.
Thank you so much.
We'll see you next time.